Uh, Good evening all. Today we are here for the second webinar of IMA-AMS, that's on Japanese encephalitis. It's an apt topic now because in Dakshin Kannada recently we had all the school children like up to 15 years vaccinated for Japanese encephalitis. So we thought this will be the apt topic, and to hear from Dr. Santosh sir will be really very beneficial to all. So at the outset, I would like to welcome everyone for the program. So I welcome our President IMA KSB, Dr. Shiv Kumar Lakkol sir, for the program. We welcome you, sir.
Thank you. Thank you.
Yes. I welcome the speaker of today, Dr. Santosh Son sir, Professor and HOD, AJ Medical College, Mangalore, and past IAP President. We are indeed lucky to have you as a speaker here, sir. We wholeheartedly welcome you. I welcome the chairperson of today's program, Dr. M.S. Rajanna sir, former professor and HOD, Department of Community Medicine, SSMC, Tumkur. We wholeheartedly welcome you, sir.
Welcome. Thank you.
Yes. I welcome our Honorary Secretary of IMA KSB, Dr. Karunakar, Treasurer, Dr. Vijay Sarthi, Secretary of IMA-AMS, Dr. Suresh Kagalkar, the Chairperson of Women Doctors Wing, Dr. Manpreet Kaur, Joint Secretary of IMA KSB, Dr. Anita D, and all the other senior doctors who have joined for our IMA-AMS seminar. So now I request Dr. Karunakar sir to kindly deliver the IMA prayer.
Unmute, sir. Unmute. Sorry. So, good evening, everybody. Thank you, and Dr. Geeta. And it's indeed highly privileged to have Dr. Srinivasan as one of the participants attending. I'm sure he's going to contribute for the learning from the process. And I must really appreciate and surprised that you could able to get on board Dr. Santosh once actually. Right? He's one of our beloved president of Indian Academy of Pediatrics. At this point of time, he's too busy with his International Pediatric Association conference at Gandhinagar, and he's agreed to come on the board as a speaker. Has been highly privileged for IMA-AMS actually. So, with this, I would like to go with IMA prayer. IMA prayer, I'll do the English thing only. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every creed and lure. Long live IMA. Jai Hind. Madam, it's back to you.
Yes,
please continue.
Yes, sir. Yes. Thank you, Karunakar sir. I request Dr. Lakkol sir to say a few words and then we'll start the webinar.
Okay. Can you hear me, ma'am?
Yes, sir.
Can you hear me? Yeah.
Yes,
Good evening
sir.
to all.
Yes, sir.
First of all, I wish all the Happy New Year. Today we are having a webinar, IMA KSB AMS. Our Secretary, Dr. Karunakaran, and President-elect S. Srinivas, and our Treasurer Vijay Sarthi, and also the Chairperson of the IMA KSB AMS, Dr. Geeta Doppa Madam, and Secretary Suresh Kagalkar, and all the esteemed members of IMA KSB. Really, I am very honored to say that today is the topic. Japanese encephalitis is the one of the important topic. Now we are facing a lot of problems. Children are suffering with this Japanese encephalitis. Regarding this, our government has taken a lot of steps to cover our children's vaccination from rural area to the headquarters also. In this regard, today we have got a very good renowned speakers, Dr. Santosh D. Sohan, Professor and Head of the Department of AJAMS, Mangalore, and past President of IAP, Indian Academy of Pediatrics President, and Chairperson, Dr. M.S. Rajanna, former Professor and Head of the Department of Community Medicine, Tumkur. See, we are very fortunate to have two stalwarts without taking much time, I hand over the mic to Madam. Please carry on. Thank you.
Thank you. Thank you, sir, for the address. Now I request our IMA-AMS Secretary, Dr. Suresh Kagalkar, to introduce our program chairperson, Dr. M.S. Rajanna, sir. Dr. Suresh Kagalkar. Okay. So I think there is some internet issues. Yeah. So we are indeed lucky to have the chairperson of today's program, the senior most person in the Department of Community Medicine, Dr. M.S. Rajanna, sir. So he will be chairing the session. So, sir, I hand over the program to you. Thank you.
Thank you. It gives great pleasure to introduce Dr. Santosh T. Sons. He is the president of Indian Academy of Pediatrics 2018, and he is the professor and head of the department and chief of Pediatric Intensive Care and Neonatology, AJ Institute of Medical Sciences and Research Center, Mangalore. He was the national president 2018 Indian Academy of Pediatrics. He is the chairperson, Scientific Committee, IPA Congress 2023. He is the founder, national president of the Organized Medicine Academic Guild of India. He was the national president, IAP, Intensive Care Chapter 2013. He is the founder president, IAP Pediatrics Intensive Care Chapter, Karnataka. He is the founder chairperson, Indian Society of Critical Care Medicine, Canara branch. He is the founder chairperson, IAP Medical Education Chapter. He is the standing committee member, Asia Pacific Pediatric Association 2019-2021. He has authorized 5 books and many publications. He is the recipient of Outstanding Asia Pacific Pediatrician Award 2018. He is the National IMA Doctors Day awardee, a person who is highly meritorious. Really, I'm happy to listen to him. Over to Professor Dr. Santosh T. Sons to give a thought-provoking speech on the burning issue, Japanese encephalitis. Over to you, sir.
Sorry, sir.
Can you see the share, the slide share?
Yeah. We can see.
Yes, sorry for joining late.
Yeah.
Hello.
We are starting with the talk. Okay, it's all right, sir. No problem. Yeah.
You can see my slide share, isn't it?
Yes, sir.
Okay, fine.
Make it full screen, sir.
Yeah, full screen. I put it full screen. Yeah. So it's a great evening to you all and a happy new year. It's a great honor and privilege to be here with you all, and respected President of IMA, Dr. Shiv Kumar, Secretary, my own close friend, Dr. Karnakar, and the host of Rajanna, who's a program chairperson, and our own Dr. Geeta Dopa, who's the chairman of IMA KSB AMS, so MC. So it's a great honor for me to be selected for this talk. And definitely this Japanese encephalitis, I think pediatricians are talking about it, and lakhs of parents are talking about Japanese encephalitis and what it is and what it's going to cause and what are the problem with taking this vaccination. I think all of us must have got this thing. So let me start with a case scenario. This is a 6-year-old boy from monsoon. He came from Haveri. He had fever for 3 days, convulsion and altered sensorium. he was febrile, he was drowsy, and he was posturing. He had decorticate posturing. There was pallor. So liver was about 2 centimeter, hemoglobin was 8, and counts was not this thing. MP, which was done there, was absent. So in this thing, this comes as any child who comes with an altered sensorium. Government has broadly classified, or it's called as acute encephalitic syndrome, or AES. That's what we do think. So possibility in our area will be cerebral malaria, acute encephalitic syndrome, which has host of diseases, and ADEM, that is acute demyelinating encephalomyelitis. It could be acute pyogenic meningitis, though it has come down with the introduction of H influenza and streptococcus pneumonia vaccine, and TB meningitis, though it's a yesteryears. A lot of cases, I think, who are in their 50s and 60s would have seen this. Now it has come down, but still you should keep in mind TB meningitis. So what is the initial management when the child comes to you like this? ABC, airway, breathing and circulation needs to be stabilized. Use cardiorespiratory status, you look, hemodynamic monitor, you monitor, and management of seizures. This child who's coming with seizures, you need to give him anticonvulsants. And very important to take a thorough history and examination. This is what will give you a clue and pinpoint your diagnosis. And of course, lab, because all these children who come with the acute encephalitic syndrome, you need to do a LP, and also neuroimaging. That is always imaging before LP if the focal lesions are suspecting. If say he has got a cranial nerve palsy, he's got increased intracranial tension features, you do a neuroimaging like CT scan before you do the LP. And of course, EEG can be done anytime. As I said, thorough history and physical examination is very important. Any child who comes with these kind of symptoms as such, so these are the options what we have. But basically, as we don't know what really is causing this encephalitis or altered sensorium, we initiate in the endemic areas, because here the malaria is common. You have herpes encephalitis, which could be there, or it could be a pyogenic meningitis. So we tend to start this child on artesunate and acyclovir and ceftriaxone in that fashion. So all these things. So what we did was we did the investigation. Protein were about 100, that is increased. Sugar was normal. Cell was only about 10 cells. All were lymphocyte. Chest X-ray was normal, low lymph nodes on the chest X-ray. Manto was about 12 millimeters. And we did a MP because they came from endemic area. MP was negative. Rapid malarial antigen test was also negative. But very important to see is in a child who come with acute encephalitic syndrome, absence of cells in CSF does not rule out the encephalitis. So it's very important for you to this thing. So what test for herpes? Because at this age, a child who's fine and suddenly started having, the foremost one what we have is in mind is, so herpes simplex encephalitis. So we do the CSF IgM test can be done. Nowadays, HSV PCRs are available, which can be easily done and can be sent. And most of this district headquarters will have this PCR, which are taken to other place and done, and it's very sensitive test for that. So here the herpes PCR was negative, but very important for you to know is that it has got a sensitivity of 98% and specificity of about 94 to 100%. So it is detectable because this virus is detected within 24 hours of illness. It can be detectable, and it will be detectable at least 2 weeks and up to about a month after the acute onset of illness. So once it is negative, do we discontinue acyclovir? Yes, you can discontinue acyclovir because sensitivity and specificity of this test is very, very good. So if it is negative, you can almost sure that it is not HSV meningitis. So thinking since it is not herpes encephalitis, so next differential diagnosis was Japanese encephalitis. So what are the tests for Japanese encephalitis we do? We usually do CSF IgM, because this will start increasing by ELISA capture method. CSF antibodies can be done, serum IgM antibodies, but only thing is that you need to have 2 pairs sample, at least about 10 days or 2 weeks interval, you need to do it. Of course, CSF, PCR, but actually what happens is in Japanese encephalitis, because viruses are detectable for the first very few days. So if the patient comes after later, you may not be able to detect this PCR test for CSF for Japanese encephalitis. So still we use the CSF IgM test for the thing. And of course, the MRI also has got a very positive points in this diagnosis, that they show, especially in this, it could be in the thalami, basal ganglion, cerebellum, all these areas you can see hyper intensity in this thing. Here also you can see bilateral hyper intensity is there in the thalami region. So here the CSF GE which we sent for IgM came as positive. This is what a typical case, usually as a pediatrician, you find it. So coming to the Japanese encephalitis as such. So around 1955 was the first time Japanese B encephalitis was isolated or diagnosed in Vellore in Tamil Nadu. Then there was a first outbreak in West Bengal. Then you had a major outbreak in 2005 in Gorakhpur area in UP and then Bihar. Almost about 6,000 acute encephalitis patients were there, and about 1,500 to 1,600 patients died every year for the next 2 years for that this thing. Even here, I still remember maybe in the 60s, there were cases in Mangalore, Dakshina Kannada area, where there was acute encephalitic syndrome, like deaths had occurred. So the piggery, rearing of the piggery was banned within the municipality of Mangalore. So every piggery was sort of shifted out during that time with the thing. As you know, it is caused by a single-stranded positive RNA. This is all this family of Viridae and Flaviviridae and Flavivirus are the causative organism. These are the RNA viruses which cause this thing. So Japanese encephalitis virus, as I said, first isolated in Japan. Why the B is that the Japanese A encephalitis was encephalitis lethargica. There's another condition which was there. So that's why for this, there was the name was given as Japanese B encephalitis. So as I said, it was diagnosed in Tamil Nadu first. Most serious illness among all the 5 virus groups of this thing. So genotypes, it's very important for us to know that there are different, almost about 5 different genotypes, that is G1 to D5. And the most common, what we have in India is G3. And some of them is slowly, G1 is also overlapping. So mostly temperate climates, you have G1 and G3. And it is most of the countries reports G1 replacing G3, especially in the Southeast Asian countries and also Thailand and all that. What they're finding is what G3 was there. So it is being replaced in some of the district. They're only seeing G1 rather than G3. So which starts becoming predominant than the G3 type. But only thing is lucky is all the genotypes form a single serotype. It forms a single serotype. So G4 consists of virus isolated from Indonesia. It's still not been isolated as, but G5, that is one from the Malaysia, which is recent, almost recent, that is 1950s. They have isolated it in the thing. So coming to the how the Japanese encephalitis spreads, usually the Culex virus, Culex mosquitoes are the ones which transmits. Usually this, what we call as a maintenance source, this waterfowls, these are the ones who have virus, but they will not have a heavy load of virus with this thing. So what happens is mosquitoes bite this waterfowls and then it bites the amplifying host. What do you call it? Why you call it as an amplifying host is these are the pigs. That pigs are the ones who are amplifying host. Here, the viral load just increases so much. So these animals, if bitten by Culex and then bites the human, the human will have the disease. But human is a dead-end host. Why? Because the amount of viremia in human is not that much. So even if the mosquito bites another human, it will not transmit because very meager amount of virus will be transmitted. So usually the maintenance host, these are the waterfowls which can cause, usually they will have, this pigs will have abortion, but also buffaloes, fowls, which is domesticized, can be the source of amplifying host in Japanese encephalitis. And now you have something like a human, as I said, like our great actors, nothing will happen to them. So they're like a dead host, and humans, after that, they will not spread for them. As you know, there are two types of Culex mosquitoes which can cause Vaishnavi and Trichonatus. The two Culex mosquitoes which can transmit this Japanese encephalitis virus. So usually what is happening is urbanization of the rural area. Plus a lot of more paddy cultivation. There are these ponds and lakes which has not been maintained, and where there's a lot of breeding sites for the virus, because there's a lot of these mosquitoes which breed there, come and bite. These are the ones which is also here, the waterfowls will be there and they can spread that. These are basically there are two types. One is egret and the herons. So these are the ones which are the host, which the mosquitoes bite, and there the viremia is there, but nothing happens to them. But it is only the human or the amplifying host can have a problem when they have that. So as you know, there is increasing mosquito habitants because of the global warming. We have seen last year, because so much of rain in places where there was no rain or meager rain, and the water sort of stagnates, and the mosquitoes come, the mosquito breeds, and you have a problem. And a lot of more and more agriculture, we tend to sort of occupy more and more this wildlife areas, and humans also proximate, especially in the rural area, the human, cattle, pigs and all that, they live in proximity. And what has happened, especially in Assam, because what they did was they immunized everybody. But the problem was now there are more adults who are having Japanese bee encephalitis or encephalitis-like symptom when you compare with the pediatric age group. So people in the endemic areas are traveling to it. This is one more thing, because now with the globalization and the increased mobility, better roads, and the people trying to find jobs there, they tend to sort of travel from the endemic area to the non-endemic area. So what happens is that chance of spreading, if they have the vector transmission, is high. So there are about 24 countries where endemic, if you see here, you just see the southern, the whole eastern southern hemisphere, or even the northern hemisphere, which is there, including India, up to the top portion of this Australian area. They're all this endemic area. There's more than about 30 million people who are affected over the time. And they say almost about there are 3 million deaths since it is known to sort of caused encephalitis in children. So these are the areas where we see the states which sort of is endemic for Japanese bee encephalitis. You can see here the green, Karnataka is also included, upper portion of the whole of UP, Bihar, Jharkhand, all these areas are known to have endemic area. Almost about 375 million people are affected in that. This is a nice slide, like a number of cases of Japanese bee encephalitis identified, diagnosed in India. That is, if you see, there are 2007, almost about 4,000, because if what happens is that only about 10% of the patients who come with encephalitis they do the LP and send for the viral markers. So otherwise there is no diagnosis. They will just treat like encephalitis. So these are the ones I would say it would be actual number will be much more than that. So 2007 was around 4,000 cases, which is identified. 2019 data around 2,500 identified encephalitis. Let us come to our own state. Here you can see there are 3-4 years data. So you see this Tumkur had about 2 cases, that was in 2019, and Haveri, that is 2022, there were about 7 cases. Dakshina Kannada, there were about 1 case in this area, which was there almost one case. But in 2012, if I have to remember, there were about 3 cases of known. One is from Kalladka, one was from Bajpayee, and one from BC Road. 3 cases of crude Japanese bee encephalitis were there. But if you see, the neighboring district has got much higher area of higher number of encephalitis thing. So coming to the symptom, this sort of a present like any encephalitis like picture, because acute encephalitic syndrome. So usually they have a prodromal fever, headache, nausea, diarrhea, all those symptoms will be, which can range from few hours to few days, the prodrome. Then some of them, it rapidly progresses with the CNS symptoms like irritability, altered behavior, convulsion, paralysis, coma, signs of increased ICP, difficulty in speech. These are all the neurological. Sometimes you can see the decorticate posturing, coarse tremor. They can have ocular palsies. All those things can happen with this thing. One thing you can make be sure is, if the child has rash on the body, it almost excludes Japanese encephalitis. Japanese encephalitis does not present with the rash. So probably it could be meningococcus or dengue type of fever. And again, when a child has the symptoms of encephalitis, so usually if it's a symmetrical sign, again, it may not be GE, it could be probably malaria, cerebral malaria. Coming to pathogenesis, it's not fully understood because it's in the southern hemisphere, northerners and the cold temperature rich countries are not really interested in that. So coming to the pathogenesis, that involves 3 type of this thing. First is that they multiply in the dermatomes or from the lymph nodes. Then they go for what is called as a neuroinvasion. Then neuroinflammation, because there they can be a damage to the endothelium or not. And finally, neuronal cell damage can occur with the pathogenesis. Coming to this 3 stages, they go for the 3 stages, that is prodromal stage, which lasts for about 1 to 3 days. Acute onset of fever, chills, headache, malaise. Then you have an acute encephalitis stage. This is the time when there is lot of CNS symptoms like high fever, neck rigidity, photophobia, all the neurological signs like cranial palsies, abnormal reflexes, paralysis, delirium, coma, all that. And finally, the late stage or sequelae, which lasts for about 4 to 8 weeks, where after the inflammation subsides, the child's neurological signs and his vitals stabilize. Then you have a sequelae like Parkinsonism, paralysis, mental retardation. These are all the sequelae which can be there. So you can sort of divide it into asymptomatic patient. If you see, for every 250 to 1,000 cases which are infected with Japanese bee virus, only about 1 will have the Japanese bee encephalitis. They can present with the mild, moderate, or severe, and some of them can die for the with this thing. And how do we diagnose Japanese encephalitis? Either you can detect the Japanese bee encephalitis virus either by antigen, genomic, or you can detect the virus in the body fluid, either by detecting the virus, or you can do a PCR or virus specific IgM in the CSF. This is the one which we mostly commonly do, that IgM, and increase in this thing. Or you can do a blood or CSF IgG or IgM, ELISA. So for this, there is need to be a 4-fold increase or greater rise in the pair stereo. You do now and do it after 2 weeks and 10 days to 2 weeks to see that there is 4-fold increase in the thing. So lab diagnosis, usually they can have, I've already told you, CSF lymphocytic pleocytosis, IgM antibodies 4-fold increase. You can do all those things, nucleic acid. Basically, what they do is the PCR, they do the nucleic acid amplification. So that's the reason why the viruses will not be there in the CSF for beyond around 4 to 5 days. So that's why to do a PCR on that is not a so excellent test for the thing. See, if you see, this is the usual way how the body reacts and produces the IgM. That is, once the infection occurs, JV is detected in the CNS and the tissue. And by about 4 days onwards, then slowly the IgM antibodies in the serum and CSF start increasing. And about 6 days onwards, the IgG and neutralizing antibodies come, which will be there for years together. That is why in an endemic area where the asymptomatically involved patients will have antibodies against the Japanese B encephalitis. That's why when a child who comes with the encephalitic syndrome, and if you do a blood test where there is you do the IgG for Japanese B encephalitis, it can be positive because they've already been infected. They have the antibodies for that. That's why you should always think of a alternative diagnosis also in a child in an endemic area who comes with these kind of symptoms are there. Coming to the differential diagnosis, all the encephalitic AES, that is acute encephalitis syndrome, can sort of thought of in that, like bacterial meningitis, tuberculosis, mycoplasma pneumonia. Again, in a little older child with mycoplasma pneumonia can be because that CSF finding is also almost like this thing. Brain abscesses, malignancies, autoimmune diseases, infection by rickettsia. This is one more thing because many of the districts in Karnataka have rickettsial infection because they can present in the similar this thing. So you have that problem of rickettsia also. It's important to think of a differential diagnosis of rickettsia. Coming to the management of acute encephalitis syndrome, it is like for every case of there is nothing new about it. So main thing is the supportive care. That is, you need to sort of make sure that his airway is maintained. Don't give him feeds because the aspiration. Many of the children may need a prolonged NG tube because what happens, they can have a pseudobulbar palsy which they can't swallow and they can go in for aspiration. If the child is not able to maintain the airway, you may need to sort of intubate, especially less than 9 GCS, we intubate the child. Hemodynamically check, make sure the circulation is fine, use the inotropes if it is necessary. Convulsions you give basically benzodiazepines, or the later you can give levetiracetam or phosphonatoin or so. And for example, if the child comes with the increased ICT, that is increased intracranial tension, you may need to use mannitol or hypertonic saline. Both can be given if needed. Control the temperature, especially high fevers, paracetamol to decrease the BMR. Circulation of then general measures like head wind elevation, neck in the mid, this thing, all this to reduce the ICP. And it's very important that we do all the AES. Please make sure you report the case to the district authorities. What's the specific treatment? Unfortunately, despite a lot of research effort, only 5 therapies has been entered randomized clinical trial, not even come out with any of this thing. The one is anti-inflammatory that they've used for the decreasing the intracranial pressure. Then all these antivirals like INF alpha 2A, ribavirin, intravenous immunoglobulin, though it did not increase the patient outcome, but increased the level of neutralizing antibodies against the Japanese B virus. Then this is the one which is minocycline, which has been used like an anti-inflammatory. This is the only drug which showed positive trend in the terms of duration of the hospital, duration of syndrome, and Glasgow Coma Scale. This thing, but still we need to have many randomized controlled trials to prove that minocycline is of any help or not. So what are the prognosis? Any child who is with the Japanese B encephalitis, that is 1/3 will be complete recovery will be there. 1/3 survive with sequelae, like they can have mental retardation, severe emotional instability, personality changes, motor abnormalities, and speech disorders. And 1/3 they have death. That is one thing about this Japanese BNK. Case fatality rate is very high. In many, this thing they have shown between 24 to 42%, especially very high in children between 5 to 9 years of age. So what are the poor prognosis? When you see a child with the Japanese B encephalitis, you should be beware of these are the symptoms. If the child presents or in your ICU, it is there with this signs or symptom, that means that this child is going to have a poor prognosis. That is, who keeps his eyelids open, hanging jaw, rapid breathing, hyperventilation. This is one more thing which basically you can distinguish other this thing, because increased ICP occurs early, so they come with hyperventilation, excessive secretion, pseudobulbar palsy, doll's eye movement, pupils not reacting, persistent of fever beyond a week, absence of response to pain, refractory seizures, decorticated decerebrate posturing are the poor prognostic sign for Japanese B encephalitis. Also very interesting is that Japanese B encephalitis can involve the anterior horn cells. So they can present just like how polio is there. So there are 2-3 articles about acute flaccid paralysis, which is presenting symptoms as Japanese B encephalitis, which should be in come. Coming to the vector controls, you can use all those, what we all know that we have used for the malaria, we have used for dengue, all this use of neem-based fertilizers, carnivorous guppy fishes in water bodies, doors you need to sort of close and use the mesh, then fogging, personal protection, and especially this slaughter of the pigs, because many areas where they have got, especially in eastern, this thing like your Thailand, Japan and all that, where the piggeries are a lot and they eat a lot of pork. So slaughtering of the pigs is employed as the containment measures. But many places, urban areas, they've shifted the whole piggery outside the metropolitan cities so that the exposure to this is much later. So what is the strategy for diagnosis of Japanese B encephalitis? So when the patients come with the probable cases, hospital, you start investigating case incident analysis. So if there is more than 10, 15 cases, most of them could be something like a streptococcus pneumonia, meningitis, Hib, Japanese encephalitis, Nipah, or others. And many of them can be negative in this thing. So coming to what is very interesting and what we are all looking forward to is about the Japanese encephalitis, why this vaccine campaign has happened here. It is important, which we never say Mangalore, except for few sporadic cases, we have never had that. But still, why the vaccination campaign has started. So vaccination was first introduced in our universal immunization program in 2006. It provided only JE in the endemic districts. So this strategy was what? So you give 1 dose of JE in children between 1 to 15 years. So that, because what they've seen is that even with 1 dose of antibodies, the dose of vaccine, the antibody level goes up to more than about 98 to 99%. So at least for some time, it will definitely give protection against the thing, because we need to see, like, after 1 dose, how long this protection is there. Campaign will be followed by JE vaccine introduction and routine immunization, because once this is over, all these children in this endemic area will be given routine immunization with as 2 doses between 9 months to 16 months of age. So why vaccination? Case fatality rate is as high as 30%. As you know, this is one of the things where that almost like a Ebola, 30% fatality rate is there, because we don't have any drug for this to cure it. So that is why the reason we need to sort of reduce this number. And permanent neurological or psychiatric sequelae, almost about 50%. That is 50% of them who had encephalitis has this problem. 80% of JE cases are in the children. So lifelong involvement of this terrible this thing. And as you know, there is no cure for JE. Treatment is mainly supportive. No clearly effective antiviral agents exist. Humans have a very low levels of JV, so usually it goes undetected until the clinical symptoms are recognized. So I said the viremia, they don't have high load, so it will get unrecognized. WHO recommends JE vaccination to all regions where the disease is recognized as a public health problem. And what is this thing is, this simple vaccine can give high protection rate. That is almost about 80 to 90% protection rate is there. And if this immunity, what is provided by Japanese encephalitis vaccine is our lifelong. So what are the vaccines what we have? India, we have 2 indigenous. So 2 indigenous JE vaccines killed or inactivated. So what we have GEAV, which is pediatric preparation is due to 1 to 3 years at 3 micrograms. And you have Genvac, what is being used during this campaign. That is Genvac Bharat Biotech. That is what that. And also what we were using in from 2006, that is live attenuated. This is a Chinese vaccine, SA 1414-2. So this is one vaccine which was used there. So government initially identified these are so many districts, especially which was rampant in Uttar Pradesh, Bihar, Assam, West Bengal, where there's a lot of morbidity and mortality also. These were the ones which were, they started with the vaccination. So they have covered about 336 JE endemic district in India. If you see all this green one, where they have completed the vaccine, you can see here number of districts in different states, which has been completed. So, and these are the yellow ones, what you're seeing are the ones which are planned, which they are going to do during this time. So, coming to Karnataka, there are 10 districts with JE vaccine under the routine immunization schedule. That is all this Vijayapura, Raichur, Koppal, Chitradurga, Davangere, Dharwad, Chikballapur, Kolar, and Mandya and Ballari. So, during this time, so they have planned that includes our Udupi and DK branch also, other than with this thing. During this December time, that we have included this 10 different districts for the thing. So what is the goal of JE vaccine? To reduce the incidence of JE in India and reduction in the mortality. But this is the main thing, because good vaccine, good immunity, cheaper vaccine, I think everybody should be immunized in the endemic area with that. So what is the duration? The target benefit is age group of 1 to 15 years in our this thing. Total duration of the campaign is around 3 weeks and could be extended. We don't know, but there's a good response that especially in DK, there was a huge response and large number of children where this thing possibly because of the campaign of COVID, where everybody has reduced the resistance for taking this vaccine in the school in this children. Coming to the what vaccine we have in India, this is the one which is being given. This comes from Bharat Biotech called Genvac. So for the government, it comes in a vial which has got 5 doses. For routine immunization in the clinic, it comes as a single dose of 0.5 ml vial. So 0.5 intramuscular is given. Government, it is only 1. For the routine immunization in the pediatric age group, we give over the age of 1 year, 2 doses at 4 to 8 weeks interval is given. So inactivated or GEAV, what we have, this again contains, which comes as a 5 dose, also single dose vial is there. There's no need to reconstitution. You can give it single dose, 0.5. And the routine immunization used only for about 3 years. You can give it around 1 year till 3 years. It is 0.25 ml twice, 2 doses, 28 days apart. After 3 years till the adolescent or even adult, it is given 0.5 ml at 28 days of interval. So inactivated, it is given IM dose. Anterior lateral aspect of the left eye is where we are given. Vaccine supply, always it is when you have a campaign, it should be the single type of JE. Otherwise, full of confusion will be there. So entire block. That's why government has selected one vaccine from Bharat Biotech and used for that thing. And it's a one-time activity. That is, this is the time when they finish all this thing. After that, it will be a routine immunization which goes on in children. So this is the IAP recommendation. I've already told you what it is. 3 types of vaccine which is available. 2 doses in the live attenuated, that is SA 1414-2, the Chinese vaccine, what we were giving in UIP, which was given. So it is given along with MMR or MR at 9 months, and again the second dose at 16 to 18 months with the first booster. And inactivated, I've already told this to the inactivated vaccine, what we have from GVAN, Genvac from Bharat Biotech, which is given. So coming to the future directions, what we have, problem is with the Japanese, as you see in India as well as in the world, there is a large number of global migration which is occurring. People from one country going to the other country, people with the endemic area of this thing going to the other country. That is same thing is happening from a rural area to the urban area. And urban area also, people who are very, very like trekking and all that, they go and go to the villages. So with the global presence of Culex vectors and amplifying host everywhere in the world, it is possible Japanese encephalitis virus could emerge outside. Just imagine how much dengue was there about 3 to 4 decades back. Hardly anything. The same could happen to the JE if we don't take care of it. Population movement, local farming practices and animal husbandry, expanding rice irrigation to meet the population demand, plausibly global climatic change, all can cause expansion of the JE into the other places, and what were non-endemic can become endemic area. And coming to the drugs of the potential efficacy, there is a lot of preclinical studies in the mice. See, basically not of much of money has been put there because this developing countries are the ones which are not affected. So there's not much of a research which is going on to this. But there are little, this thing which is a lot of work is being, especially monoclonal antibodies on their pentoxifylline. This is again a TNF alpha inhibitor has been used, etanercept, TNF inhibitors. These are the newer drugs to treat the Japanese bee encephalitis vaccine is in the research mode. Hopefully down about 5 to 10 years, we should get some insight into that. And these are the other one, Artemisinin and RNA-based therapy, especially this RNA-based therapeutics like this anti-micro RNAs has showing some amount of promise in this regard. And of course, this drug repurposing agent, that means to say that there are some drugs which are used for something else. Ivermectin was a classical example which we all used during the COVID. Same thing, ivermectin also may be having JVNS3 inhibitor, it is there. Like that niclosamide also. These are the drugs which are repurposing drugs which are being sort of looked after. So what are the challenges in vaccination? Vaccine immunogenicity and the need for booster doses, neutralizing antibody titer more generally accepted. So that's a problem, that whether booster dose is required in the seronegative recipient. And there could be emerging, because luckily what has happened is whatever vaccine, what has been licensed, that is for the genotype of JE3 of JEV. But these vaccines provide a good thing for all the multiple thing. We have 1 and 3 basically, but even against the 2nd and 4th also, it produces some amount of this thing. So these are some of the challenges what we have, whether there are new genotypes which come, whether this vaccine will be efficacious to us is one thing what we have come. Coming to the summary, that is take-home messages. Japanese encephalitis has got a high case fatality rate and high percentage. Because if you see, that is one of the things where almost about 50% of them have some problem. And it's a vaccine preventable disease. And the vaccine is cheap, easily available, and can be sort of without any much side effects it is there. No specific treatment is available yet because you don't have any drug. like meningitis antibiotic. We don't have anything. So when there is no specific treatment is available, optimal supportive care is paramount importance, and prevention takes the great the driving force. It is necessary to enforce the vaccination in the endemic area. It is our duty as doctor to make sure in an endemic area, with so much of sequelae and such case fatality rate, we should make sure every child less than 15 years take this vaccination. Thank you so much. Thank you.
Rajanna sir, please unmute yourself, sir. Rajanna sir, please unmute yourself.
Can you hear me?
Yes, sir.
Thank you, Dr. Santosh, for your lucid presentation of JE. And you mentioned very methodical presentation, the agent, the geographical distribution, laboratory investigation, limitation of treatment of JE, and also about the vaccine. So, control of reservoir. What is the reservoir of infection? And it is a amplifying reservoir. That is the pigs. And that too, the young pigs, not the adult pigs. Sometimes they say young pigs, piglets are the reservoir of infection. So if we say the young pigs should be isolated, the owners of the pigs, they will not allow. In fact, the corporation issued the strict instructions to isolate all the piggeries, but there was influential pig owners. They came in the way. Then blocking the channel of transmission. How it is transmitted? Culex vishnui, Culex tritoneurinchus, Culex bitoneurinchus. So this, fortunately, this Culex mosquito bites in the night time, and also it is zoophilic in nature. So it prefers cattle blood rather than human blood. So especially in the rural area, people sleep even in the cattle shed. So the Culex mosquito may bite even the human beings, but it prefers animals. So it prefers animals. Then so we have to control regular and proper use of mosquito net and use of mosquito repellents. Aedes mosquito, it is a daytime biter, but this Culex vishnui, tritoneurinchus, bitoneurinchus, these are all nighttime biters. So regular use of mosquito net. And then Dr. Santosh clearly in detail, he mentioned about the limitation of vaccine, and it is incorporated in the national immunization schedule in the endemic area. So thank you very much. Now it is open for discussion. Those who are having any question, you can ask question. Thank you, Dr. Santosh, again.
Thank you so much.
Yes, sir. So we have few questions in the chat box.
Yeah.
What is the efficacy of Japanese encephalitis vaccine, sir? That is one question.
Yeah, Japanese encephalitis vaccine is quite good, all the vaccines. But if you see that even the Chinese vaccine, which were there since long time, almost about 50-60 years, that has given a very good, even in China, or it is almost about 300 million doses have been administered. And many of the places, the endemicity has gone. They don't see any this thing, and saved millions of lives with that. Even with our Indian, the Kolar strain, what Genvac uses, or live the killed inactivated vaccine of SA14-14-2 also has got a very good efficacy. The titers, almost about after the first dose itself, was about more than 90%. But only thing is, we have to see how long these titers are there. whether we need the booster. But as per the companies' literature and their studies, they say even 2 doses are more than effective. In fact, Genvac has come out with the study, a single dose is as effective as 2 doses has been there.
Yes, sir. Thank you, sir. So one more question. The prognosis of Japanese encephalitis, is it same or different in adult and pediatric age group?
Pardon me? I just missed
The
it.
prognosis of JEB, is it same or different in adult versus pediatric age group? Prognosis
No.
of the infection.
Prognosis of the infection, because it is much more in the pediatric age group, because the sequelae, the long-term problems are 100 times more in pediatric. Adult are usually mild infection. So even the ones what they have seen in Assam, where there is a shift of infection from a pediatric to adult, it is usually much milder, not with the long-term sequelae of what we see in the pediatric age group. And if you see, for every 250 to 1,000 cases of JE infection, one case will have a severe encephalitis-like syndrome.
Yes. Then what are the conditions where a child cannot be vaccinated, especially if the child has fever? So that is one more question, sir.
Yeah, when the child has fever, it is better not to vaccinate with any of the vaccination. That is there. Any child who has been given immunoglobulin, any child who's on cancer therapy, any child who's on steroid for a longer time, and neuroprogressive diseases and uncontrolled seizures. These are one of the few of the conditions where it is better we don't give this vaccine.
Yes, sir. Then one more question. Should women of childbearing age be given the vaccine before pregnancy, as this JE has serious effects if it is contacted in first or second trimester?
See, what has happened, these are all inactivated vaccines. Inactivated vaccine would not have any effect on that. It is not a live vaccine. Live vaccine should not be given. If you see that first Chinese vaccine, which was a live attenuated vaccine, that is contraindicated. But inactivated vaccine, like for example, toxoid, you give a toxoid can be given. Like for example, we give Tdap. So those are the ones can be given, inactivated ones.
But routinely, should we immunize the women of childbearing age group, sir, with the JE vaccine? No.
At the moment, no, we don't have, because adult, it is very this thing. That is a government this thing.
No, sir. Could I just ask Dr.
Yeah.
Manpreet, sir? I'm a gynecologist.
Yeah.
Sir, Karnataka is endemic for Japanese encephalitis, as you said. So even though it is a government prerogative and they are going to decide, just like some of the other vaccines like HPV, but supposing it's a patient who comes concerned and they want to know whether they can get a vaccination done for JE because Karnataka is endemic, should we say yes and go ahead if she's in the childbearing age but not pregnant as yet, planning a pregnancy?
See, for these kind of things, we need to have a clear-cut government policy. These are the endemic this thing. So unless we get a government clear this thing, what is there on the policy on this, I think we should not go ahead and do it on our own. Say, for example, HPV. So even boys has been given in Australia and all those things, but here we don't give it. It's something like that. So we should be very careful when we administer, and if something happens, and if the government has not come out with a policy about it, it will be a difficult thing to sort of handle.
Okay. So one more question, like somebody is traveling to a place like Uttar Pradesh. Do they need to take the vaccine, adults and children? Or not?
What IAP as well as WHO says, if you're staying in that place for more than 4 weeks, then you're supposed to take it.
Okay.
More than 4 weeks.
Okay. Thank you so much, sir. Thank you.
Yes,
Very
thank
informative.
you,
Thank you.
We have Dr. Venkata Chalapati, sir, our past IMA president. Sir, do you want to add anything, sir? Venkata Chalapati, sir?
Good evening, everybody. Good evening, sir. Dr. Santosh, sir.
Good evening, Venkata Chalapati. Nice to hear you. Nice to see you.
I have nothing to add because it was almost like an oration. So no question of asking any questions to a veteran like Dr. Santosh Shons. Sir, it was a wonderful talk. You have covered everything. And particularly certain things were like gray areas, like vaccinating a pregnant woman or a childbearing age. There also you have given a clarity. And I think there are a lot of take-home messages in your talk. And I think I really congratulate, and I think I should congratulate even our team of IMA KSB, who brought in a very, very busy pediatrician of Asia Pacific to the IMA KSB platform to deliver a wonderful lecture. So I thank you very much for giving this talk, sir.
Thank you.
Thank you so much.
Thank you, sir. We have our immediate past president, Dr. Suresh Kudva, sir, who also is a pediatrician. Sir, do you want to add anything or say anything about sir's talk?
No, Dr. Soans has covered everything. It was a very lucid talk, and all the fields of are well covered. I think this is one of the best talks we ever heard in IMA KSB. Thank you, Dr. Soans, and we need your such talks in future too. Thank you.
Thank you. If everybody excuse, can I leave the thing, because 9 o'clock I am supposed to be a chief guest in one more program, virtual program.
Yes.
No, I am
Yes,
very
sir.
sorry, because this is our launch of a PG. This thing, I am a medical education chapter president also, so that's the reason why I need to leave. Huh? Thank you so
Yes.
much, everybody,
Thank you.
for such a
Yes,
wonderful
sir.
Thank
evening
you.
with you
Thank
all.
you.
Thank you
Yes,
so
sir.
much.
Yes,
you.
Thank you.
Thank you. Thank you,
Thank you
sir.
very
Thank you very much, sir, for
Thank
joining.
you, sir.
Yes,
Dr.
thank you.
Soans.
Yes.
Bye-bye.
Dr. Rajanna, sir, do you want to say anything?
No, it is a thought-provoking information, and clearly he explained everything: control of reservoir, blocking the channel of transmission, protecting the susceptible population, the limitation of the vaccine. So all these things. And this larvivorous fish, we cannot leave it in the rice field. We can introduce larvivorous fish in the lake, pond, small tank to control the this Culex mosquito, and that is the only. And Culex mosquito breeds in contaminated water, compared to Anopheles mosquito breeds in clear water. So this is about my.
Rajana sir, one question, sir.
Please.
Regarding in the COVID status, what is the prognosis of JE in the era of COVID status?
COVID itself causes immunosuppression, known to cause immunosuppression. So JE, it is an iceberg. So as Dr. Santosh mentioned, everybody infected with JE will not develop paralysis, encephalitis. So in immunocompromised individual, more chances for them to develop Japanese encephalitis. So we should be careful. It is better to protect them by giving 2 doses of vaccine.
Thank you, sir. Yes.
Sir, thank you
We
very much.
have our IMA KSB Vice President, Dr. M.B. Rajeshri Madam, who also is a pediatrician. Rajeshri Madam, do you want to say anything about this topic? Dr. M.B. Rajeshri Madam? Okay. Yes, we have Dr. Padma Prakash also, who has joined. Anyone, if they want to give any inputs or any doubts, you are please free to unmute yourself and kindly ask, sir. I think there are no doubts. Yes.
Sir has covered everything.
Yes, yes. Both the sirs have covered everything. Yes. Yes. Now I request Dr. Suresh Kagalkar, our Secretary of IMAMS, to kindly deliver the vote of thanks.
Yeah, thank you, madam. So, vote of thanks. First of all, I should give thanks to the Dr. Santosh Soans sir, who is a famous and very experienced pediatrician, and also the past president of IAP, and who has delivered a wonderful talk. And we all members of the IMA, we enjoyed, and it was all the corners of the topic has been covered, and very well appreciated by our all senior IMA members. So thank you very much, sir. Santosh Son sir has left, and on his behalf, I should say thankful to you, sir. Once again, we will see in such a platform in the future also. And also, I thanks to Dr. M.S. Rajanna sir, who has agreed our invitation. And last time also, sir was a speaker in the IMA Academic Subcommittee. Now also, I welcome you, sir. And also, you have covered all the doubts. And when you are a chairperson, the program was very much successful. And the congratulations goes to you, sir, Rajanna sir. And
Thank
once
you.
again, meet you in
Thank
the
you.
such a platform, and you are such a wonderful personality, and our IMA is proud to say that Dr. Rajanna sir is coming and again in our platform. Thank you, sir.
Thank you.
And
Thank
so,
you.
thanks to our President IMA KSB, Dr. Shivkumar Lakol sir, who is in his busy schedule, who has agreed and this time has joined. And also, hello,
Hello,
yeah,
hello.
Yes, sir.
We can hear.
Yeah.
and
Go ahead,
also.
sir.
And thank you to our secretary, sir, Dr. Karunakar, who has prayed for the IMA prayer. And also, I thank to Dr. President-elect Dr. Srinivas, sir, who has joined. And also, I thank to Dr. Venkatachalapati, sir, who is a senior office bearer of the IMA headquarters. Venkatachalapati, sir, thank you, sir. And also, I thanks to all the IMA member and our Dr. Suresh Kudwa, sir, who is ex-president of IMA. Thank you for joining, sir. And will you and all the IMA members, I must say thankful. And once again, and also I'm thankful to all the members of the WDU members, Dr. Manpreet Kaur, madam, and other member also. And also, and all the viewers also, I must say thankful. And also, we'll see you in the next coming month with the first Wednesday in the 8 p.m. with a different good topic. Thankful to everyone. Good night, sir. Good night, everyone.
Thank you.
Okay.
Thank you.
Yes, sir. Yes,
Good
sir.
night, good
Yes,
night.
sir.
all.
Thank you.
Good.
Thank you,
Thank you,
everyone.
sir.
Thank you.
Yes, yes.
Thank you, Geeta
Good
ma'am.
night.
Thank you.
Yes, thank you. Thank you. Yes, sir.
You are
Bye,
you are
doctor.
sitting in the car and giving vote of thanks. Traveling.
Sir.
Mobile vote of thanks.
Hello, Dr.
Thank you.
Anita.
Good night.
Yeah, yeah.
Good night, everybody.
Yes, good
We had
night. Good
nice
night, sir.
time.
Thanks a lot, sir. Thanks a lot, sir.